Now it is my pleasure to invite Dr. Nimi, Assistant Professor, RAO Trivandrum, to present her topic on investigations and management of ocular viral infections.
Good morning, all. I'm thankful to Dr. Papa and KSOS for giving me such a great opportunity to present in this prestigious conference. My topic is how to diagnose and management of the viral diseases, the taming of villains. First of all, let me talk about the herpes simplex keratitis. As Dr. Jasmine has already mentioned, there are various types: epithelial keratitis, stromal keratitis, and endothelial keratitis. In epithelial keratitis, it is diagnosed clinically. The characteristic dendritic pattern is there, linear dendrites with, what we can do is staining with rose bengal and fluorescein dye. That is double staining. Rose bengal will take up the margins, at the margins of the ulcer, and fluorescent will be stained at the base of the ulcer. In very rare cases, you can do a corneal scraping in atypical cases. Treatment is basically with topical antivirals, that is, you can give topical acyclovir 3% eye ointment 5 times daily, or even ganciclovir gel is available, which can be given 3 times daily. And it has to be continued till the staining becomes negative. Oral acyclovir, oral antivirals are not indicated in epithelial keratitis. Stromal keratitis, it is without ulceration. Topical steroid is the mainstay of treatment. It can reduce the stromal inflammation and shorten the duration of the course of illness. And here you can give oral antivirals in the prophylactic dosage, that is oral acyclovir 400 milligram BD or valacyclovir 500 milligram OD. Here you can give topical antivirals. As we are using topical steroids, we can use topical antivirals to prevent epithelial keratitis. In necrotizing stromal keratitis, therapeutic dose of oral acyclovir is given, that is 800 milligram 5 times daily for the first 7 to 10 days, followed by the prophylactic dose. Topical corticosteroids are given once the epithelium heals. In endothelitis or disciform keratitis, again oral acyclovir is given in the therapeutic dosage, that is 800 milligram 5 times daily. There are other options as well, and you can give topical corticosteroids. Apart from these, you can give adjuvant therapy like cycloplegic and AGM whenever needed. So there are a few indications of oral antivirals in herpes simplex keratitis. It is given to prevent scarring and to maintain viral latency, and also to prevent recurrence. So there are the specific indications are more than 2 episodes of stromal keratitis a year. There are multiple scars on the cornea and lesions involving the visual axis, endothelitis, and patients undergoing ocular procedures like keratoplasty, cataract surgery, and ocular procedures, other laser procedures, and in immunocompromised patients. So these are the drugs that are given for antiviral prophylaxis: acyclovir 400 milligram BD, valacyclovir 500 milligram OD, and famciclovir 250 milligram BD. The optimal duration of prophylaxis is not fully established, but for at least 1 year it is recommended. Neurotrophic keratitis, the aim of the treatment is to promote epithelial healing. So we can give generous use of lubricants, autologous serum, and patching, and finally you may have to do tarsorrhaphy to promote the epithelial healing. Coming to more commoner, adenoviral keratoconjunctivitis, again the diagnosis is clinically, we are doing it clinically, clinical diagnosis. Certain tests like rapid adeno detector, PCR, viral cultures are all available but not routinely used. Treatment, it is self-limiting. Within 2 to 3 weeks, it may resolve without any complication. You can start on lubricants and topical antibiotics to prevent secondary bacterial infection. In acute phase, topical corticosteroids, it is controversial. Indications include the presence of pseudomembranes, subepithelial infiltrates in the visual axis, and severely symptomatic patients with severe lid edema, photophobia, chemosis, etc. Disadvantages of using topical corticosteroids. The lesions may recur on stopping the steroids, and long-term side effects can occur, like cataract and glaucoma can occur. So it has to be discontinued. And in some certain studies, it has shown that providone iodine along with topical dexamethasone may be useful. Maybe you can put it in a single setting or multiple settings. In non-responding cases to steroids, you can use topical cyclosporine or topical tacrolimus. So coming to the posterior segment lesions, the treatment, this viral retinitis is common, and acute retinal necrosis, the characteristic features are there. So it is also a clinical diagnosis. You can see the peripheral necrotic retinitis patches along with vitritis, occlusive arthritis and all. And you can do an aqueous or vitreous tab, send it for PCR, and very rarely you can do an endoretinal biopsy. Treatment is basically with systemic antivirals, intravenous acyclovir 10 milligram per kilogram, ethali for 10 to 14 days. You have to give as an induction dose, and followed by a maintenance dose of oral acyclovir 800 milligram 5 times daily for at least 3 months. In unresponsive cases, intravitreal injections like ganciclovir or foscarnet can be given, which have to be repeated 2 to 3 times a week, and systemic antivirals to be continued along with the intravitreal, and after 24 to 48 hours you can start them on corticosteroids. ARI has got a high rate of retinal detachment. You can do a prophylactic laser, but it is controversial. And those who develop RD, you may have to do PPV, though the poor visual outcome is very poor. Extended antiviral therapy may reduce the incidence of contralateral disease by 80% over 1 year. In progressive outer retinal necrosis associated with HIV infection, CD4 count less than 50, combination of intravitreal ganciclovir along with intravitreal acyclovir is found to be useful. They may need long-term maintenance and antiretroviral therapy. CMV retinitis, again it is a clinical diagnosis. PCR can be done with aqueous or vitreous tab. Treatment, intravenous ganciclovir is the drug of choice, and maintenance of oral valganciclovir. Along with intravitreal ganciclovir in vision-threatening lesions. It can be stopped in HIV patients with good immune recovery after 6 months, ART naive patients only for 6 months if there is good immune recovery, and ART experienced patients long-term maintenance therapy is needed. EBV retinitis is similar to ARN, and systemic acyclovir is the drug of choice. Key takeaways: you can diagnose a clinical viral retinitis by detailed history and thorough clinical examination. Initiate antiviral therapy without any delay. Do not wait for lab investigations, and close monitoring and long-term treatment is needed for these patients. Thank you.
Thank you, Nimi, for enlightening us how to tame the viral infections by proper investigations and the correct treatment to be given.